I'm Selena Gore. I'm the CEO at Women Heart here in the US, and I have the pleasure of moderating today this conversation about sex differences in the diagnosis, treatment, and care of heart disease in women. And as I was reading our brief, it struck me that how we are talking about this is that these are recent developments. There's new interest in heart disease in women, or there's a growing call for healthcare providers to be looking at heart disease in women specifically and uniquely to men. And I think for any one of us on this panel, we would argue that we've been beating this drum for decades. And I think part of what we're seeing, at least at Women Heart, is that we're seeing the consequences of some sex disaggregated analysis that wasn't being done before. So now we're actually saying, as you just said earlier, it's shocking when we do these analyses. So I'm very happy to welcome our panel to talk a little bit more about the detail of what this all looks like. Just to say 2 words about Women Heart, we are a patient-centered organization based here in the US. And what we do is we educate, advocate, and support women living with and at risk for heart disease. It is a mission that I'm passionate about as somebody living with heart disease. It is something that we focus on here in the US, but we are increasingly being called on to bring to other countries around the world, which is a very happy thing for me to be able to do. Because I think in many places in the world, including the country I was born in, women's voices are just not even part of the conversation. So I'm very happy that here at the Heart Cafe we're having this conversation today. So just very quickly, I'm going to introduce the panelists. We have Professor Mamas from Kiel University, who's a professor of cardiology. We have Dr. Bavararini Ramu from the University of Minnesota, and she's an advanced heart failure and transplant cardiologist. We have Dr. Cesar Herrera, Director of Cardiology in the SEDIMAT Cardiovascular Center in Santo Domingo, Dominican Republic, and Dr. Leslie Cho from the Cleveland Clinic, who runs the Women's Cardiovascular Center and is section head for preventive cardiology and rehabilitation, and also is the chief quality officer at the Cleveland Clinic. So we've got a wonderful panel. So we'll just sort of kick it off from the top, and I'll address the first question to Professor Mamas. In your extensive research and clinical experience, what do you think are the most significant sex-specific risk factors for cardiovascular disease that healthcare providers should be considering when assessing and managing women's cardiovascular health, and probably to add, probably have not been considering for a long, long time?
So my group, led by Ponce Wu, who's an obstetrician, has done a lot of work around risk factors during pregnancy, because certainly we see that perhaps that's one of the very earliest periods when you have expression of the cardiovascular phenotype. And so things like history of preeclampsia, how many of us, when we see a woman in clinic, do we ask about pregnancy-related disorders? Have you had preeclampsia? We know that having preeclampsia predisposes to an increased risk of cardiovascular events, something like threefold. Diabetes, when you have gestational diabetes, again, marked increase in diabetes at 10 years. Multiple pregnancies, premature pregnancies, again, very important risk factor. But also thinking about things like assisted reproduction as well. I mean, there's a lot of observational data coming out now suggesting that women that undergo assisted reproduction are at much greater risk of future cardiovascular events. When we're seeing people or women, either from the primary prevention or a secondary prevention perspective, we're not considering these risk factors, and we're not including these risk factors in many of the risk stratification tools that help us guide provision of evidence-based therapy. So in the UK, I'm a British cardiologist, we use something called QRISK, and QRISK has lots of factors in it from a primary care perspective, things like socio-demographics, deprivation, smoking, cholesterol, high blood pressure, inflammatory disorders, nothing to do with pregnancy history. And I think that's really quite an important area that we're missing in the treatment of these patients.
Just to follow on that, in turn, what do you think are the most effective approaches to educating both healthcare providers and patients, the general public, about the importance of this approach to, as they're calling it, personalized cardiovascular care of women, but it's addressing risk factors specific to women?
So whenever I see either a man or a woman in the clinic, I always ask them, do you know what your wife's blood pressure is, if the wife's there, or do you know what her cholesterol is, do you know what your mother's cholesterol is? And often they don't, and that's really important when you ask that question to people. And I think that's one of the biggest things that you can do as a physician in clinic, to ask those questions, to make people think about these questions. You may see someone post PCI, the wife is there with them, you can open that conversation with her and say, hey, do you know what your blood pressure is, do you know what your cholesterol is? And a lot of the time you're met with a blank stare, as if, why is this important? Women don't get cardiovascular disease, we get breast cancer, it's not important for us.
Yes, I'm guilty of demonizing breast cancer as well as sort of the disease state that gets the most attention when really it should be cardiovascular disease. But so let's move on to Dr. Ramu. As a researcher, we know that you specialize in gender disparities in cardiovascular care. What are some key findings or insights that you have found in the work that you're doing that highlights sort of the unique challenges that women face?
Great question, and I'm an advanced heart failure cardiologist, so a lot of my perspectives are based on differences and disparities related to heart failure in women, which is again a very important consideration. And when I talk about sex disparities and differences, I think it's important to highlight two things. One is biologic sex differences. So there's pathophysiologic differences. For instance, men have a lot more of heart failure with reduced ejection fraction because they are more prone to macrovascular coronary artery disease. They develop acute MI, which is a well-known antecedent for HFrEF. In contrast, women have more of coronary microvascular dysfunction. They have endothelial inflammation, which are key factors in driving HFpEF, which women are more prone to. But these are also pathophysiologic mechanisms for stress cardiomyopathy, Takotsubo cardiomyopathy, which women are more prone to, and also uniquely women experience peripartum cardiomyopathy, where again these play a role. So there's these sex differences in pathophysiology, there's sex differences in sex-specific risk factors, as Professor Mamas was just saying. One is pregnancy-associated conditions, but also breast cancer. Though we think breast cancer is worse, breast cancer and its therapies particularly predispose women to heart failure. So not only are they more prone to traditional risk factors like hypertension, the risks associated with hypertension leading to heart failure is probably threefold higher in women as compared to men. So women not only suffer the consequences of a disproportionate impact of traditional risk factors, but they're also uniquely prone to sex-specific risk factors. So these are, again, what I club into sex differences, which are explained by biology. And then the elephant in the room is the main thing, which is sex disparities, which is beyond biologic differences. And these disparities are what is historic exclusion of women from cardiovascular clinical trials. There is implicit bias when we take care of them. We tend to ignore their symptoms. We are less responsive to their symptoms. And women with heart failure, someone I was talking to yesterday was saying how their NIH grant for studying women in heart failure was declined on the pretext that women live longer with heart failure than men. So the question is, where is the disparity? But that extra survival that women have is marred by worse symptoms, poor quality of life. And so does that extra survival actually help? And so I think I think these are kind of the major things that come to my mind, and of course we can talk more about exclusion of women from clinical trials and so on, but definitely women with heart failure, in my mind, are unheard, they are understudied and undertreated.
So to just continue on in that train of thought, how do you think this is exclusion has impacted even further sort of the way we currently understand cardiovascular disease in general? And then what do you think we can do? What are the steps that you think are necessary to expand that inclusion to make sure that, we're not standing here 20 years from now having the same conversation?
Great questions. And so, there was a recent paper which reviewed 33 randomized clinical trials. These are all the landmark clinical trials in the space of heart failure from 1995 to 2020, 2000, sometime in the 2000s. The recently published heart failure guidelines used the same timeline to develop their guidelines, using the data from the same clinical trials. And in those 33 clinical trials with hundreds of thousands of patients, women constituted 20%, 22% of the study population. So we treat women with heart failure based on our guidelines, which were developed by hardly including women in the same studies that we're using to develop those guidelines. So there is a historic exclusion of women from clinical trials, disproportionate to the prevalence of heart failure in women. And so if we are not studying women, if we are not reporting sex-specific interaction with treatment, we are not going to be spending the time to understand those sex differences, whether it be in pathophysiology or how do they tolerate this drug, what is the recommended dose for women, because their pharmacokinetics are different. They probably need different doses than what men need in terms of our heart failure therapies, because they're more prone to adverse effects, and we don't study those. Most of these trials excluded women. Most of them did not report a sex and treatment interaction, which is important to know how sex modifies the treatment effect. Most of them do not report sex-specific adverse events, which we need to know. And so I think the second part of the question was, how do we change this? And it's really by a multifaceted approach. We need to stop using sex-specific exclusion criteria. We need to be reporting sex and treatment interaction of any therapies we are studying. We need to be reporting sex-specific adverse events. And people who are running the trial need to look like the participants they're trying to enroll. And so we need more women in leadership roles in running clinical trials. And that can only happen if we educate them and train them to be successful in those roles. So I think we need regulatory agencies to make sure that study sponsors are mandating including a diverse participant in clinical trials and looking at their enrollment strategies and looking at how they can enhance participation.
Great. And then sort of a last question before I move on to our next speakers. So how is sort of cardiovascular disease influenced by the various factors? We've talked a little bit about this, but hormonal fluctuations, socioeconomic status, cultural norms, how can sort of the clinician, right, in the very limited time they have with patients, not address these things, but integrate these things into the way they assess risk?
Hormonal fluctuations across the lifespan of a woman's health have cardiovascular implications, from menstrual cycles to pregnancy to postpartum hormones, prolactin, which is implicated in the development of peripartum cardiomyopathy, and also postmenopausal risks. As estrogen levels decrease, women are prone to more cardiovascular issues and so on. So all that have considerable implications of how hormone impacts a woman's risk of cardiovascular health. And then we talked about socioeconomic status. There's increasing recognition that race is a social construct, and differences that we see, health disparities related to structural determinants of health and socioeconomic status, play a key role in access to healthcare services, the ability to get to appointments, the ability to afford medications, and the ability to have a caregiver take care of whoever you're taking care of so you can get to those appointments. And all those, unfortunately, have greater implications on women. A woman of a lower socioeconomic status is going to be implicated even more and suffer even more because of these issues. And cultural norms, definitely. The cultural norms affect a woman's body image and issues with weight. It affects her ability to focus on herself, because we are all guilted into being the primary caregiver for whoever we care for. And to put that aside and to care for ourselves is breaking cultural norms. I'm from India, and it takes a lot of conversation to even make people think about that as an option. So I think really as healthcare providers in this field, and with a passion to improve cardiovascular health in women, we need to be focusing on these. We need to be making sure that women have access to providers who look like them, who speak like them, who understand their cultural norms. We need to provide culturally appropriate and concordant care. We need to take that appropriate pregnancy-related history, because that is unique risk factors that we are not including in our risk estimators. And we need to, if we want to enroll women in clinical trials, we need to go that extra step to figure out what is her barrier to getting to my study. Can I help with transportation? Can I help with providing funding for caregiver and other things so that we can help them be successful?
Thank you so much, Dr. Ramu. I'm going to go on to Dr. Cho. We know that you have experience in preventive cardiology, Dr. Cho, and we'd love to understand from you how you think about sex-specific risk factors when we talk about risk assessment tools, right? Cardiovascular risk assessment tools are important. We talk about risk assessment all the time, and yet they seem to be inadequate for what we're talking about today.
Yeah, I mean, for sure, the risk assessments currently are not gender specific. They should be gender specific. There's some data from the Framingham that you can increase the sensitivity if you increase HSCRP, but even now those tools are pretty outdated. And I think, as Dr. Mama said, you need to include pregnancy data. I'm very proud to be part of the CLEAR Outcome study, which enrolled 48% women. In the 13,000 patient trial in the modern era, it enrolled the most amount of women. It enrolled the most amount of Hispanics. And I'm also very proud to have led the paper on the ACC Cardiovascular Disease in Women committee paper on how to increase diversity in clinical trials. And one of the things that we found is that in the modern era, 40% of clinical trials, 40% do not have one single female investigators in their steering committee or in their executive committee, 40%. Only 10% have, females in their steering committee. The other thing is that women continue to get their care in a general practice setting and not in a subspecialty setting. And because they don't even make it to the subspecialty setting, they can't get into trials. And I think it is on all of us to force that issue upon industry, upon regulators, and upon the payers.
I'm just really happy to hear all the things that you've already been doing. And when we go back to think about, again, the inadequacy of the current tools that exist, what can healthcare providers do? What can the cardiologists at this conference do now to improve their care for women, given that the tools they have aren't great?
I think as we continue to push the boundaries forward, we recently published data on even things like mitral valve disease. So the current guidelines, all their metrics is based on body size that's in men. So if we wait as long for women, they actually have more heart failure, they have poor outcomes. We have to, on every front, not just in prevention, but in valve disease and in hyperlipidemia, in every single facet of cardiology and in aortic diseases, really try to demand a gender-specific guidelines and recommendation. And it's more than just gender, right? As you know, there is whole ethnic differences because the body size for Asians are very different than Caucasians. And I think trying to find truly that personalized way of looking at cardiovascular care is critical.
So we talk about women having atypical symptoms, which I don't like to use that term, but I think that there are symptoms that are more obvious, let's say, or more understood in the mainstream. But we also know that women are underdiagnosed, are misdiagnosed, have delays in diagnosis. What would you recommend in terms of increasing awareness for patients and providers to recognize what we're sort of naming here atypical symptoms in women?
I mean, I think continued education is the only possible way, right? But I do think, like, if you look at registries, 70% of women have typical symptoms, right? It's the 30% that have quote unquote atypical symptoms. The other thing is women continue to get their EKGs later when they even show up to the emergency room for their STEMIs, even in the modern day era. Women continue to show up later into the presentation. So we need to, as you said, hit it from both patient as well as provider perspective.
Taking it from the angle of the patient, what can we do to empower women patients to come in earlier? I mean, I think that's a common, not criticism, it's a common point that providers make to say women themselves present later. So what can we do for women so that happens less and less?
I think using our general internal medicine doctors, our family practice doctors, to get risk assessment earlier. By the time you go see a cardiologist, that's one thing. But just lifting the prevention in the entire cohort by engaging our general internist, our family practice doctor, really, they see the women with preeclampsia, gestational diabetes, 20 years before we ever get to see them.
Absolutely. Let's move on to Dr. Herrera. Your work has really emphasized on the importance of cultural sensitivity when we think about approaching cardiovascular care. Can you sort of share examples of interventions or programs that have been successful in addressing these barriers and in fact improving outcomes for women with cardiovascular disease?
Yes, this is a World Heart Federation panel, so I'm going to try to navigate from within the States and outside the States, since I play both roles. I'm based in the Dominican Republic, but I work in New York at Einstein. In Latin America, I would say it's work in progress. In the U.S., there's many examples that I can give you, but in our institution at Einstein Montefiore specifically, the hospital serves a very challenging community, one of the poorest counties in the U.S., where every one of the social determinants of health factors that we talked about here, except rurality, because it's in the middle of Manhattan, plays a significant role, particularly in heart failure, and particularly among women. I say that because most of those patients are Latin American patients or African Americans, and in both communities, women play a very important social-cultural role as family leaders. They tend to delay their care after they care of their mother, their husband, their children, their neighbors, and their friends. So these are very real issues. Issues of return to clinic, language. The second generation members of the family, the kids are busy in school or working. They cannot always translate. So looking at all those issues, Ileana Pina came up with a great idea a few years ago. I don't know if you've seen the ACC patient navigation project. Not a project, is a sort of a plan that is suggested for hospitals that are carrying a lot of patients with heart failure with a high recurrent rates of readmissions. So what was done was pick a team of PharmDs and nurses, culturally sensitive, language sensitive, and what we implemented was a plan to educate patients and relatives upon discharge of their heart failure needs, diet, etc. Give them the return appointment for 2 weeks, specifically hour, time, and location, provided with the first 2 weeks supply of medications, regardless of the insurance status, and making a follow-up phone call a week later. And what Ileana showed with that plan that we use on a daily basis is that we reduce the readmission rate by 80%. let alone all the educational benefits. These are not, huge money-needing interventions. These are efforts that the institutions can do fairly easily as long as you have cultural sensitivity, which I think is the main factor to lead to success. In Latin America, I said it's work in progress because we need registries to begin to understand what women and heart disease is about. We have an interest in heart failure in women in Latin America and published an editorial in the Journal of Cardiac Failure last month. Some members of the group are present here in the audience, calling for action to begin gathering data to then implement steps towards improving that. Because obviously, as I said, social determinants of health, cultural beliefs, ethnicity plays a huge role in women and Muslim women.
Congratulations on that success. I was taking notes because I think, I find that often both physicians and hospitals are reticent to put in these programs because they think it's expensive. But I think, to your point, they don't have to be. They just have to be thoughtful and intentional. We've already talked a little bit about hormonal influences and pregnancy-related complications as it relates to heart disease. Can you talk about how healthcare providers can perhaps tailor prevention and treatment strategies in these cultural contexts to address these challenges for women to optimize cardiovascular outcomes throughout their lifespan?
Well, I'm going to answer that in two different ways. Number one, those of us who have a little bit of gray hair were not exposed to this important discussion back when we were training. You can just go online and open up a publication from Jack from 30 years ago, 25 years ago. I was very little discussed about these issues. So I'm really happy that that's happening now, particularly with the young faces present here today. I think it begins with us leaders, educators, engaging our trainees to make them understand that the history is not just whether you took the pills yesterday or not, it's whether you understand what the prescription said, whether the neighbor or the relative should be the person to contact on that particular patient because culturally that person may be closer than the husband or whatever. So I think it begins with our own participation as physicians and as healthcare system. I'm sure you've seen this paper. There was a paper published last year, I'm referring to Dr. Chow's comments, that looked at, in a university hospital, looked at patients admitted with advanced heart failure who were candidates for advanced therapy, and they weren't even referred to their local experts. So it begins with us as physicians. The second part of the question I'll answer with cardiobstetrics. Both in the US and the section of cardiobstetrics published this paper a few years ago, and also in Latin America, we mirrored that survey and just presented it here in this meeting. The training and the education of cardiologists and cardiobstetrics is quite, I'm not going to say non-existent, but it's quite limited. So again, it begins with our own education on this subject. We cannot teach a patient if we really don't know how to approach that. Just like in the US and Latin America, the majority of clinicians either don't work in a hospital that has a cardiobstetrics expert, or they feel uncomfortable treating those patients, and many of them actually did not get trained for that. So it begins with training and education.
And that's really important because we know that so many women use their OBGYN as their sole provider of healthcare in this, at least in this country, and certainly in many other places as well. So that could not be more true. I'm going to put on the spot Dr. Mamaz and Dr. Herrera as clear allies in this fight. What do you think? I mean, representation is important. We know that. For those of you who know Dr. Nanette Wanger, I was sitting with Dr. Nanette Wanger last night. She's a phenomenal person, and I sat with her as we were sitting in the Women in Cardiology lounge for this reception, and I said, what does this make you feel looking at these hundreds of female cardiologists here today? And she says, Selena, the first time we convened this council, this Women in Cardiology section, the room was as large as a broom closet. And look at this today. And I just, so representation, we've gotten better, right? Look at this audience. We've gotten better. We're getting better. But as we know, in the US, only 14% of cardiologists are women. So that alone, it's not going to change anything in our lifetime, right? I cannot, in good faith, tell a woman with heart disease, find yourself a female cardiologist. That's how you improve your outcomes. we're setting them up for failure, especially in places where there aren't that many cardiologists to begin with. So my question to the gentleman on the panel is, what can we do to improve allyship among the male cardiologists? Because we have, it can't be either or, it's got to be both.
I guess there's several things. So first and foremost, mentorship. I think that's really important. I think that giving opportunities to women and recognising women. I mean, no one's doing anyone a favour here. We have so many brilliant women, very academically capable women. Sometimes, though, men are more likely to promote themselves, and I think you have to look beyond that and give opportunities to women that are often much harder working, much brighter, much more capable. So I think that's first thing. Second thing is to value women in the workplace. So, for example, one of the things I really fought for, which I thought was disgusting, was in my university, I have a lot of women on my team, and some of them breastfeed, and they were having to do it in the toilet, and that's just not appropriate. So making your workplaces much more welcoming. Also thinking about promotion of mid-career women. I mean, I think we're doing really well in trying to promote some of the younger women to come through, but what you often find is that women sort of go to mid-career level, and there's not really then the structures to promote them thereafter, and it's really difficult. Often women will have interruptions in their journey, in their career. If they have children, they'll take time off, they'll raise the children. And so if you're sort of assessing CVs, you may see a gap of some years. And I think, being cognizant of why there's a gap rather than to go, well, this person's not productive. But I think you've also got to look at structural aspects. And I think the structural aspects is something that's really important and we don't think about. So on, say, committees, you should have a woman that's at least as senior as a man on any interview committee, because you often say that yes, we're giving women opportunities, but when you've got an all-male committee or a committee led by a man and very junior women, then it's very difficult to give equal opportunity to women. And finally, you've got to look at your own metrics. It's not great to say, well, we support women, but we've got an all-male faculty, or 10 out of our 12 people who got promoted this year were men. So you have to look, you have to collect the data and look at what you've got. And I guess the very final point is to for true equity, things like salary. I mean, I don't think it has to be completely and utterly transparent. I mean, in the US, you don't have transparency around that. In the UK, you do. I mean, everybody gets a salary, and everybody's salary is poor, and your salary doesn't depend on, my salary is exactly the same as anybody else doing any other speciality that's 14 years post-fellowship. It's a national pay system, so I don't get any extra benefits, but you don't have that in the US. And so you've got colleagues doing very similar roles being paid very differently, so you need that transparency.
Well, there's very little I can add to that, but let me say a couple of things to that question. I think that it is a huge issue because it goes beyond us individually and as physicians. It's a cultural issue, it's a societal issue. And depending what part of the world you live, it may be less or more problem, more relevant or less relevant of a problem based on those factors. But we're not politicians. We cannot change that directly, but we certainly should participate and promote that change. But I think the change begins individually. I think again, those of us who have some leadership positions, particularly with young trainees, we have to lead by example, and I think we have to make sure our institutions and our leaders, particularly medical and non-medical leaders, understand this issue, number one, and embrace it proactively. It's not, okay, fine, we only have 40%, 24% of women enrolled in the heart failure trials. We only have 40% of authors or investigators. We have to create the policies to make sure that does not continue to happen. We have to be proactive. I mean, the college is a great example of a professional organization that does that. If you want to be in a committee, you have to take all kinds of trainings. You know, you have to understand, you know, what discrimination is, what implicit bias is, and all of those things. So I think it has to be an effort, individually, societal, and also whatever institution you work on. Otherwise, it's not going to happen.
Well, and I might add, sitting on panels like this is also really important. That you know, just lending your voice to this conversation, I think, is also critical. I'm gonna open it up to. Oh,
If I may add a comment.
of course, yes.
Sitting here next to these allies and listening to them speak, I mean, I felt like Professor Mamas was reading my CV when he was talking about some of that. And, you know, my own pathway to being a cardiologist as an immigrant and, you know, going through visa issues and other things else. So I'm definitely going to take you up on the mentorship.
Are there any questions from the audience, first of all? And while you think of your question, because we should have good questions, I also wanted to bring up this idea. You know, one of the earlier questions was around empowering women, and I think that what we hear from the patient community of women is that by the time they have a cardiovascular condition, they're in their doctor's office, they are so vulnerable, so compromised, so exhausted, so many things, to then say, it's up to you to figure out the right way to get a diagnosis or the right medication or the right treatment. It's yet another thing that, you know, so, and I'm not saying that, you know, the patient community is saying, no, we can't take anymore, but I guess my question is, how do we create some sort of system-wide change that allows women to kind of, you know, be supported in this effort, right? I mean, we haven't talked about like a really big thing that I think a lot of patients experience, which is simply women not being believed. Like, it's a very simple thing, and it's such a sort of endemic thing that happens. So in that context, how do we help patients? I'm not going to use the word empowerment, but you know, have some readily available tools to make those conversations easier. Anyone can take that.
I'm an interventional cardiologist, so of course I do Manoka. I do pressure wires for people with microvessel disease. And for decades and decades, women have been told that it was all in their head until, you know, we have good data. And of course now with that technology, they're being diagnosed. And you're absolutely right. There is that whole issue. And same thing with statin intolerance. I know there's very evangelical feelings, but it's true. Women have more intolerance to statins. I think in the modern day era, you know, women have the power of the internet to search. And I think using that, they have a patient group or whatever. And I think finding your the physicians, I mean, it's out there because we run a very large spontaneous coronary artery dissection clinic. We have an FMD clinic. We have Manoka clinics. And so like trying to really find the right provider. But you're absolutely right. There is that huge sort of disconnect.
I mean, the other thing that we haven't really spoken about, and I think it's, you know, the big elephant in the room, is the intersection between race and female sex. I mean, you know, the inequalities that we're talking about don't happen as much to white women as they do to women of colour. So, for example, you know, we all talk about social determinants of health. When you look at, say, the UK heart attack registry, we published this a few months ago in Heart, there's not really a social deprivation gradient for white women. If you're a woman from the lowest deprived background, your quality of care isn't that different from someone of a much higher background. Whereas if you're a black woman, you know, completely different. And I think that's a really, really important thing to say, that yes, cardiovascular health consistently, irrespective of what region you look at, and heart attack care, you know, even in a health service like the UK, a national health service, so you could forget about, you know, ability to pay, ability to have insurance. It's a national health service. every region of the UK, women get worse heart attack care than men. But amongst women, it's not the white women that get the bad care, it's the women of colour. And really that's where, in my view, we have to focus both in terms of a patient level, but also physician level. You know, those are the women that I think, you know, I mean, in the UK, you know, we don't have many women cardiologists. We hardly have, I can't think of a single black woman cardiologist in the UK. And that's really, you know, a big wake-up call, I would say.
So your question really is, how do you empower patients to participate in their care, in the cardiovascular care? I think two comments I'm going to make. One is, I believe it was 20-something years ago, there was a nice study published that looked at the improvement in blood pressure control among African Americans. I believe it was in Tennessee or Alabama, using barbershops and churches to motivate the patients and relatives themselves to follow up their blood pressure medications, to talk about it, to measure their own blood pressures. I mean, you would think that that's very simple, but that's incredibly impactful, because these are the very centers of exchange, social exchange, that this community has. Flipping the coin, how many programs are out there of patient advocacy for breast cancer survivors? Great, many. Lots, that's great. Do we have heart failure, women in heart failure or post-heart attack programs like that? There are some, but it is not the cultural thing to do. But when it comes to cancer survivor, yes, good for them. But we need to begin to do that.
I really appreciate that comment, because as I said earlier, I think we know that at least half of women think that breast cancer is their number one killer. We know that's not true. And yet we are behind as a cardiovascular community in stepping up the patient support element. Women Heart does that. We are an organization of women with heart disease, and we do provide that peer support. In 2 weeks, we're going to launch the global patient council for women with heart disease. So we are doing these, taking the steps, but you're right. I mean, we are far, far behind the cancer community. So do we have, Lana, any questions from the audience? No? Okay, so in the interest of wrapping up early, since we don't have questions, I'm going to pose one last question to the panel. Recently, Dr. Jill Biden, along with her husband, the president, he signed an executive order, right, on women's health. Yeah. Women's health research. It's a big initiative, and what he's asking for is $12 billion of funding. I know this is in the U.S., but I want you to take it on as if it was in your own countries. What would your greatest wish be for this funding as it relates to cardiovascular health? Just imagine, let's just say for argument's sake, an unlimited amount of money that comes into research for cardiovascular health in women. What would the research questions that you would want answered be? Let's start here, and we'll go down the panel that way.
As Dr. Clay Yancey said yesterday in a panel that we shared, we don't need more drug studies to look at minorities and women. We don't need more procedures. We need to know how to implement what we've learned properly in every underserved community. That's what we need to do.
Are you about to say my favorite words, implementation science? Because that's what we've got to do.
I agree. I think the AHA statement that just came out this week on implementation guidelines for promoting health equity has never had a more prominent and an urgent need than we do now. And I think we have evidence to say we have these differences, we have evidence to say we have these disparities, and we know what is there. And I think looking for more answers in terms of, do these disparities exist? I don't think we need that anymore. I think we need to be focusing on implementing what we know in reducing those barriers.
If I had $12 billion, what would I do?
Is the question.
Okay, if I had to spend it wisely, I would say I wouldn't spend it on drugs, I wouldn't spend it on research. What I would spend it on is what I think will have the greatest impact on cardiovascular events, and that's spending it at the population level. The biggest drivers of cardiovascular disease, or any disease for that matter, education. Okay, I think if you look at data from across the world, women consistently with lower levels of education will have much worse cardiovascular mortality, cancer mortality, any other mortality you want to look at. So number one, invest in education for women. Number two, social income. Often, if you look at, say, many different parts of the world, we've got to move away from the US-centric focus. Poverty impacts future health much greater in women than it does in men. So if I had all that money, I wouldn't waste it on, I'm an interventionist, I wouldn't waste it on stents, I wouldn't waste it on statins, poverty, education.
I'm a big proponent of patient-centered outcomes research, and I think in the U.S. we have a PCORI network, and I think, oftentimes we give drugs, we give all these things to women, and they don't want to take it. And I think trying to understand in this era of shared decision-making, the patient-centered outcomes, what things matter to them. Because it's very different for women as for men. I think that should be where the money is going to be spent. I'm just going to make an editorial comment, and that is, unfortunately, the Biden administration is not going to spend it on that. That is, it's the $12 billion is more for entrepreneurial sort of business development, which I find incredibly sad.
Yeah, that's right. I mean, there's I don't know how many times I use the word innovation in that report. But I think what we're hearing is we've got the basics. We've got the basics. As a former mentor would say to me, we know that the health outcomes happen in the healthcare system, but the causes of those are outside, Dr. Manos' point, outside of the healthcare system. And so we unfortunately are seeing the consequences, right, of the challenges that happen outside in society. I would like to invite you to help me thank this wonderful panel. I leave this panel at first disheartened, but really optimistic that we've got these leaders who are really thinking about these issues on behalf of women around the world. It is obviously a topic that I live and breathe every day, and it's a topic that I think we will continue to see grow here at ACC, at AHA, and all other cardiovascular venues. So thank you to our panel.